So I've been asked to speak about ICD outcomes in patients who are at risk for sudden cardiac death. My job is a little bit like writing a critic for the success of this particular movie. We all know that the implantable defibrillator is the most effective tool that is available to us for prevention of sudden death due to VT or VF in patients with LV dysfunction. And its life-saving potential is known to us beyond doubt. However, it's expensive. So what I will try to focus during the course of the next 10 minutes or so is to see is how we can identify patients better so that we can maximize the outcomes of these very expensive devices in our not so wealthy Indian population. If you look at the demographics of sudden cardiac death, I think this is a lot of work done by Highgrave. The Indian data shows about 750,000 patient incidents of sudden cardiac death every year with an expected survival which is less than 1%. So obviously there is about 20% of these individuals are less than 50 years of age in the most productive age of their lives. And there are several mechanisms, all of you know, of sudden cardiac death, which includes VT, VF, and pause-dependent torsade, and sustained monomorphic VT degenerating into VF and asystole. So considering that there are several mechanisms for sudden cardiac death in patients with LV dysfunction, it is difficult for us to imagine that there is a single parameter that would identify these patients who are at risk of sudden cardiac death. And also there are factors such as presence or absence of underlying heart disease and the stage of heart failure, considering that how advanced the stage of heart failure they are, and that also is an important factor. And therefore, if you look at the classical indications as per the guidelines, we know that patients who are survivors of a sudden cardiac arrest, like these are the secondary prevention patients, ICD is a class 1 indication, and patients who have hemodynamically documented unstable VT or a syncopal VT, ICD is indicated, and patients more than 7 weeks, more than 6 weeks post-MI, if they've had an EF of less than 35% and NYHA class 2, class 3 heart failure, and non-ischemic cardiomyopathy with EF less than 35% and NYHA class 2 and class 3. These are the classical indications as per the guidelines. But if you look at the pie of the secondary prevention in LV dysfunction, only 8% of patients survive a first episode of sudden cardiac arrest. Therefore, what we are targeting in secondary prevention is only 8% of the total pie of patients who actually deserve an ICD. And in many patients, the first episode of sudden cardiac arrest is their last and only episode, and they do not survive to tell you a story. And therefore, this is this 92% of patients at risk for sudden cardiac arrest that we need to address and focus on, and that's what is primary prevention. If you look at the primary prevention population, patients with class 2, class 3 heart failure with LV dysfunction have a 35% risk of sudden cardiac arrest over the next 5 years. And in patients post-MI with low EF, there's a 10 to 15% risk over the next 2 years. And if you look at the ICD utilization in our country, it is less than 2% penetration. That is less than 2% of patients that require an ICD get the devices due to various reasons. And the most important being that financial affordability. If you look at the MADI-2 guidelines, which are widely used in the developed countries, if you look at the MADI-2, the number needed to treat is the number of patients you need to treat to save one life is about 18 lives. Therefore, the cost of saving one life would be around this figure. It's about, I think, 70 lakhs. So that is from a social and a socio-political point of view in the present scenario where the cost is a major issue in all medical treatments. So this is an important factor that we need to identify. Therefore, people have come up with the concept of neither primary prevention nor secondary prevention, but like 1.5 prevention, which is somewhere in between primary and secondary prevention. There is no doubt that secondary prevention, we have to give an ICD, but in terms of patients who are for primary prevention, can we identify patients who are better and do what we call a 1.5 prevention. So there are several risk factors identified. One of them is, of course, the most important of them is an ejection fraction of less than 25%. And there's a definite correlation that the risk for sudden cardiac death exponentially increases below ejection fraction of 30%, and it's greatest in those who have an ejection fraction of less than 25%. And in patients who have non-sustained ventricular tachycardia is an important risk factor for sudden cardiac death in patients with LV dysfunction. There are ample evidence in literature from several randomized trials that shows that there is a strong correlation between sudden cardiac arrest risk and the presence of non-sustained ventricular tachycardia. And similarly, presence of frequent PVCs of more than 10 per hour is an independent risk factor regardless of the ejection fraction. In patients without LV dysfunction and patients with LV dysfunction, more than 10 VPBs per minute is a significant risk of sudden cardiac death in these patients. And presence of syncope, unexplained syncope in patients with LV dysfunction is an important risk factor for sudden cardiac death, so much so that patients with cardiac conditions with a high risk of sudden death who have unexplained syncope, this is considered to be a secondary prevention indication rather than a primary prevention indication. It's assumed that they have already had survived a sudden cardiac arrest episode. So there's ample evidence that secondary prevention, ICDs, improve overall death rates as well as arrhythmic death rates. And primary prevention also, there are several trials which comprehensively show there's a 34% reduction in all-cause mortality and a significant reduction in arrhythmic mortality. And the reductions in mortality in the primary prevention trials are equal to or greater than those in secondary prevention trials. So therefore, how do we identify patients better among those that require possibly an ICD for primary prevention? One is the MUST prediction algorithm in the MUST trial, which is one of the landmark pioneer trials. They have postulated a scoring system. If the EF is less than 20% or less, the score was 20 points. EF of 40, the score is 0. And 1 point for every percentage less than 40, between 20 and 40. Inducible VT carries 17 points. Hospitalization carries 16 points. Presence of intraventricular conduction defect, left bundle branch block, carries 11 points. Non-sustained VT, which is not less than 10 days after a coronary bypass, has 18 points. And history of heart failure is 20 points. So this is how it's calculated. And you can see that with the score of less than 30, there's no significant difference between the 2-year event rates and the total mortality or the arrhythmic death. So this is an example of 25% ejection fraction patient with a past history of CABG, NSVT within 10 days after a CABG, no LBBB or non-specific IVCD, no heart failure, no inducible sustained VT, and the score is 15 points. This patient obviously wouldn't benefit much from an ICD because there's a 2-year total mortality risk is pretty low. So there comes the NICE guidelines, the British NICE guidelines, which according to them, ICD is indicated in patients with a history of MI, more than 4 weeks previously, and either all of LV dysfunction, that is EF less than 35%, NYHA class 2-3 heart failure symptoms, non-sustained VT on Holter, and inducible VT on EP testing. This is pretty stiff criteria. Or if the EF is less than 30% and NYHA 2-3 heart failure and the QRS duration of more than 120 milliseconds. So these are the guidelines and which are more appropriate for us to probably adapt in our country. And of course, a short note about patients who have who are waiting for heart transplantation. A significant number of them, if you look at the heart transplant data, 25 to 30% short-term mortality while they are waiting for a transplant, and 50% one-year mortality. And 65% of these deaths are sudden deaths which are preventable by ICD. Therefore, these are yet another indication for ICD for primary prevention of sudden death in patients waiting for heart transplantation. Thank you very much.